everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today by Dr. Ben Thrower, who is with us to answer all your questions, as many as he can within the next hour. I'd like to introduce him. So Dr. Ben Thrower is the Medical Director of Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta. He previously served as the Medical Director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the Senior Medical Advisor for MS Focus and the Multiple Sclerosis Foundation. And he enjoys contributing to our quarterly MS Focus magazine. So we're very pleased to have him join us. And like always, he does answer quite a few questions very quickly. And if you are, let me give, for those that are not familiar with how we do this each month, if you have a question, you can either put it into your chat down at the bottom, or preferably in your Q&A. You'll see that at the bottom also in that app. If you want to ask your question live, all you have to do is press the raise hand button, or if you're on your phone, you just hit *9, and I'll go ahead and unmute you. You have to say okay to that, and then we can go from there. So here we are, Dr. Thrower, another month. Let's see. I see we already have one in there.
Awesome.
So let's see. Patty wants to know if there's anything for neuropathy. The sensory issues in her feet are affecting her walking, especially with shoes on. She has no pain though, which is great.
So when we talk about changes in sensation with MS, she raises a good point. So there's loss of sensation, and specifically when you lose position sense, it definitely can affect your walking. So if you're tilting one direction or the other and you can't feel that tilt, it's going to affect your balance. And so we don't have anything yet that's going to restore that sensation. So we rely on our physical therapist friends quite a bit. We know with physical therapy that we can improve balance. Sometimes that's through core strengthening to help you adapt to those changes in position. Do be aware that if you don't have good position sense in your feet and your balance is off, your brain is going to try to use visual cues to make up for that. So when you're walking, do be aware that you don't want to take your visual cues away. So, if you're walking, focus on walking. Don't look at the person next to you. Don't get up in the middle of the night with no lights on because you've taken your visual cues away. Be cautious in the shower if you're washing your hair or washing your face and you're closing your eyes because there's nothing soft to land on in the shower. So those are all things that we can do to work around that loss of balance. If pain is an issue, fortunately she doesn't have pain, but there are a whole world of medications that we have out there if there is discomfort associated with the changes in sensation. Oops, you're muted, Deb. You're still muted. There you go.
Thank you. So Barbara sent this in through email. She said, do you know how well low dose naltrexone 4.5 milligram works for MS pain? Does it work for sciatica pain, helping with spasticity? Can it be used with baclofen?
So years ago, there was a lot of interest in low-dose naltrexone. So naltrexone in its usual FDA-approved version is a 50 milligram dose, 50 milligrams. It's an opioid receptor antagonist. So it was meant to help people get off of addictions to prescription painkillers or maybe recreational opioids, heroin, things like that. There was interest in the MS world in a much smaller dose, as she mentioned, the 4.5 milligram dose. It's taken just at bedtime. I will say early on when this first kind of hit the MS scene, there was a lot of hype, and I think it was inappropriate. It was almost touted as a cure for MS. It clearly is not that. But so there have been some controlled studies where they've looked at how people do with this. And there is something there. It does seem to improve some measures of quality of life. And when people say they feel better with low dose naltrexone, usually it's either pain is better or energy levels are better. It's certainly something to look at. So the thought is if we partially block these pain receptors in your body, that your body may make natural endorphins to overcome that blockade so that you could have some pain control with it. It's a fairly safe thing to do. We don't know of a lot of drug interactions, so you certainly could use it with baclofen and other antispasmodic agents. So I'm open to trying it. There usually is not great insurance coverage because it's an off-label dose of the drug. This is a form of naltrexone that has to be compounded. It has to be made in a mom and pop pharmacy to get that lower dose. If you shop around a little bit, you can sometimes find better prices at different compounding pharmacies.
Wonderful. Someone's asking, aside from vitamin D, what other supplements are good for people with MS to take? They're considering magnesium glycinate, taurate, and malate, vitamin E, vitamin C, berberine, all of those.
So that's always a common area of interest in the MS community, and it's challenging because you can find little bits of evidence for a lot of these supplements, and if you followed all of that and you ended up taking everything where there's a little bit of evidence, you probably end up with a tackle box full of supplements in your cabinet or refrigerator. I think in my opinion, there is good evidence for vitamin D. There are some MS centers out there that are not quite as sold, but I do think that vitamin D does have anti-inflammatory properties. What most studies have suggested in MS is that if we get the blood levels up above 50, that you start seeing a lower risk of new MRI lesions, a lower risk of relapses. We do have to be careful with vitamin D. All of your fat soluble vitamins, A, D, E, and K, you can overdo it with them. So typically with vitamin D, we like to know what your blood level is and then make appropriate dosing recommendations based upon what that blood level shows. On the other supplements, I think a good resource for people is Dr. Alan Bowling's books on complementary and alternative therapies in MS. I think he's on his 3rd edition now. He does a good job of going through different supplements and trying to give some consumer guidance on what to take. For me, if I were choosing for myself, I would definitely know what my vitamin D levels are. I would probably take a look at things like turmeric because there is some good evidence there in the animal model of MS and some human evidence. Outside of that, I probably would take a look at Dr. Bowling's book again, because past that, there are bits and pieces of evidence, but I think it gets a little bit thinner at that point.
Okay. And what are your best tips for managing jet lag after going across multiple time zones?
Yeah, that's so. I mean, that's an issue for all of us, MS or no MS. So hydrate. When you get to where you're going. Some people would argue that the best way of dealing with jet lag is to wherever you go is to try to jump into that time schedule as much as so, if it means going to bed on that new time schedule, getting up on that new time schedule, it's going to be a little painful for probably 24 hours or so. And if you're dealing with fatigue from MS on top of that, yeah, it may mean you're using whatever treatments you use for your fatigue, but most people would say it's best just to jump in and get into that new time schedule as quickly as you can.
Okay. Is there any word on when satx will become available in the US?
So satx or nabiximols would be an potentially FDA approved version of cannabis. So it's the GW Pharmaceuticals out of the UK. It's a 1-to-1 CBD THC sublingual spray, kind of like the old Banaka Blast, that has been used for spasms in MS. Unfortunately, it doesn't look good for satx in the United States. So there were trials. We were part of those studies, and in my opinion, they picked the wrong thing to look at. They picked something called the Ashworth scale, which is a measure of spasticity in MS. To my knowledge, no form of cannabis has ever changed the Ashworth scale in spite of lessening spasms. They had one negative trial with the Ashworth scale, and I think a business decision was made to not pursue any further studies for satx in the US. So unfortunately, it's approved in 23 other countries around the world for spasms and MS, but I haven't heard of any new study plans for us here in the US.
Thank you. Elizabeth is asking, is the RSV vac okay for PWMS?
As far as we know, it is. So so it is a new vaccine. Obviously we don't have any long-term studies in people with multiple sclerosis, but based upon the type of vaccine that it is, it would appear to be okay. It's interesting that my wife's a pediatrician. Obviously, in infants, RSV is a big deal and can end up, have hospitalizations. We just haven't seen it to be a huge, issue in most adults with MS. I honestly, even in our folks who are potentially immunocompromised due to our various MS therapies, I don't think I've seen hospitalizations from RSV. So I'm not pushing it for people with MS. I don't have any problem with someone getting it, but I'm not, leaning on people and saying you must get it. I would prioritize probably your things like your annual flu vaccine, maybe shingles vaccine if you're above a certain age. But we'll continue to watch and see if any more data comes out on RSV vaccines.
Ala would like to know, what about BMT for MS?
BMT.
I don't know what that is, but that's what they wrote, BMT.
I'm assuming she might mean bone marrow transplant.
Maybe.
Maybe is this someone that typed in?
They typed it in. What about
maybe they can clarify that. I mean, I'm going to go with bone marrow transplant. It's kind of like charades. I think that's what she made. So BMT or HSCT, hematopoietic stem cell transplantation, is basically a way of rebooting your immune system. With hematopoietic stem cell transplantation, you could, if you look at cancer management, those individuals, they are frequently getting someone else's cells. So they're finding a closely matched donor. So we call that allogeneic. In MS, we do autologous. So that means you're getting your own cells. The advantage of getting your own cells is you can't reject them. They're yours. So you don't have to be on an immunosuppressant for the rest of your life to prevent rejection. The data is still coming in. Every year seems like we learn a little bit more about HSCT and MS. It clearly is a very effective therapy. It's not quite ready for everybody for prime time. You still have to get high doses of chemotherapy to wipe out your existing immune system. So it's not a risk-free procedure. The risk has gotten better over the years. I think when I first got into the MS world years ago, there was about a 5% mortality rate associated with autologous hematopoietic stem cell transplantation. It's getting close to zero. Now it's not zero, but so right now, in studies, what they're primarily focusing on would be individuals with very, very active inflammatory MS. Lots of relapses, new lesions on MRI, and they probably have failed at least 2 of our existing disease modifying therapies, so that the risk is worth it.
Julio would like to know any information on Octave MSDA test.
Yeah, so Octave is a private company that has developed a blood panel of inflammatory markers looking at MS, and so it kind of falls into the whole arena of biomarkers. Biomarkers, it's a broad category, but when we say biomarker, one way we think of that is a blood test that might tell us kind of what your MS is doing. One of the interesting biomarkers, and this is part of that Octave blood test panel, is called neurofilament light chain. This is a marker of axonal breakdown. So if nerve fibers are being damaged, neurofilament light chain is going to go up in the bloodstream. It definitely is a valid test. I think the struggle for a lot of us right now is I'm not sure quite what to do with it yet. I certainly wouldn't discourage anyone from getting the Octave blood test panel. I just don't know quite yet, until we get more data on biomarkers, quite what we would do with it. So let's say we have you on a highly effective therapy, Yeah, and maybe your MRI is stable, you're not having relapses, but this blood test comes back a little bit abnormal, or it shows that there are some markers of inflammation or axonal damage. I don't know what we do with that quite yet. So yeah, I'd say stay tuned. It is certainly an area of a lot of interest, in terms of how effective our therapies are. Could we use tests like this octave, biomarker to determine when to take people off of therapy in the future? Maybe someone is 60, 65 years of age, their MS is very stable. Could we use these blood tests as some sort of reassurance to stop therapies?
And Patty's asking, after I eat, her energy level goes down. It gets worse. Is there anything to alleviate this?
So, when we eat, our body there are a lot of things going on. So you're shunting blood to your gut to help, break that food down. Your insulin levels would go up, to try to handle that blood sugar. So there could be a metabolic component to that. She might experiment with different types of foods. Is it a high carbohydrate meal that's more likely to cause fatigue? Is it the volume of the meal? So maybe eating smaller meals with a higher protein content, lower carbs spread out through the day. It may take kind of playing around with things. I would certainly make sure that that she's getting annual physical exams and there's no other diabetes or thyroid issues, anything like that might be contributing metabolically also.
Okay. Rosemary says, I'm almost 71. I have never taken DMTs. I was recently diagnosed with SPMS or PPMS, not sure which at this point. Because I am JC positive, I prefer to stay away from the HE DMTs. Would a bajio be beneficial for me to take at this time?
So, at 71 years of age, I think we really have to think about what is her MS likely to do going forwards. If her MS, if her level of functioning seems to be fairly stable, over the past 5 years, 10 years, I think there needs to be a serious discussion about, does she need to be on any DMT? Could she realistically just focus on, staying healthy, keeping active, maybe watch her vitamin D levels, make sure those are up in a good range. If it is decided that a DMT is warranted, a bajio would certainly be on the table for discussion. We use a bajio in settings exactly like this. So it's a nice, oral therapy. It's got a fairly low side effect risk. There's not a significant risk of compromising the person's immune system. So I think if it is decided that she needs to be on something, I would certainly keep a bajio in the discussion.
Okay. We have Tricia saying, can MS be a cause for sensory changes and pain, burning, stabbing in the skin of the groin and pelvic genitalia area? And what can be done about that to help?
So anywhere on the body is fair game for altered sensation with multiple sclerosis. And so when we say altered sensation, unfortunately, in some people, it's not just plain old boring numbness. It's altered sensation plus pain, hypersensitivity, burning, shock-like sensations. We don't want to fall in the trap of automatically blaming MS for every pain that comes up. But if, through her neurologist, primary care doctor, other physicians, if it's determined that, okay, there's no other explanation for this discomfort other than MS, then there certainly is a whole world of options out there for pain management. So if that is her MS that's causing that would kind of fall into the category of central neuropathic pain. Typically, when we look at neuropathic pain, if we're going to use a medication, if it's a limited area of involvement, you could think about topicals, topical lidocaine, topical CBD, things like that. If it's a little too big of an area of involvement for our topical, then we're going to look at an oral medicine. Most of the oral prescription drugs are either going to fall into the sort of antidepressant camp, antidepressants that are being repurposed to manage pain. So these are things like duloxetine or Cymbalta, are older antidepressants, nortriptyline, amitriptyline. And then we get into the anticonvulsant camp. So these are more things like your gabapentins, Lyricas, medicines that are anticonvulsants are being repurposed for that purpose. Cannabinoids, medical marijuana would certainly be in the discussion for pain management like this as well.
Okay. Carrie's asking, she tried to clarify this in a second message, but basically she says, how can you tell if your body is healing? She had said she doesn't take any meds, steroids, etc. I don't know what she's doing.
I mean, if we're talking about healing as it relates to MS, and that's I don't know that we have a way of knowing that. So we do know when you think about damage in the brain and spinal cord, you're damaging the myelin, you're damaging the axons. Humans do have the ability to make new myelin. Even if we don't make new myelin, so the body can reestablish electrical conduction across a demyelinated nerve fiber, even if you don't fix that myelin. It might not be as effective as it was before the damage occurred, but it does work. To the best of our knowledge, there's no way of fixing nerve fiber damage yet. So once a nerve fiber has been transected, we don't think the human body repairs that damage. Even if we don't heal or repair, the other way that our body might sort of deal with an injury like an MS lesion is through rerouting. So neuroplasticity, or forming new pathways, is the other way our body can sort of respond to an injury like a multiple sclerosis lesion. So we don't have a great way of measuring that other than looking at how someone's functioning. So when we look at standard MRI, we don't think that standard MRI is a great way of measuring repair in the central nervous system. Clearly, standard MRI doesn't measure the rerouting, the neuroplasticity. There are some other MRI techniques that might measure remyelination, but those are primarily used from a research standpoint right now. It's a big area of interest because where we would like research to head is towards neural repair, fixing the damage, restoring function, and we'd like to have measures to show that objectively.
Okay, so how well do edibles work with baclofen for spasticity management?
So we do have patients that use both edible cannabinoids, whether it's gummies or candies or oil by mouth, along with their standard antispasmodic, whether it's baclofen or tizanidine. If I have someone who's on baclofen or tizanidine and they're going to add some form of cannabis I usually have them continue their present dose of baclofen and gently add that cannabinoid, and then depending upon how well they're doing with that, then maybe we can back off on the baclofen or tizanidine slowly. What it'd be ideal if we could get rid of it altogether, but even just lowering the dose. So we did, and others have done these studies as well. We collected data on our patient population who were adding cannabinoids, cannabis in some form, to their medical regimen, whether it's for spasticity or other pain management. And we found on average they were able to reduce their prescription medication use, things like baclofen, tizanidine, by about 50% on average.
Thank you. Do you have any information on the once a month Copaxone? Should they still be developing low efficacy DMTs, or is it a waste of resources?
Yeah, we always, I don't think, but from our standpoint, just if you're a person living with MS, if you're a healthcare provider working with MS, we always welcome more tools to the toolbox. I get where they're coming from. Our bias when we manage people with MS is we want to use more highly efficacious drugs, to be as aggressive as we can, but there is still a place for those other therapies. And we still have people on old injectable therapies. Maybe they've done well with these therapies over time. Maybe that individual has a low tolerance for risk. They just don't want to go on a bigger gun medication. So yeah, I think the use would be very small, but there probably are people out there who would still fit into that camp where some form of a Copaxone would still be something they would think about.
Thank you. My new neurologist has asked me to consider changing from Ocrevus to Kesimpta because of the ability to better manage infection. I have not had any infections or illness while on Ocrevus 5 treatments. Patient reviews make me hesitate to switch. Can you comment on your experience with patients on Kesimpta, severity of side effects versus benefits? This person was diagnosed with PPMS at age 70, or maybe they are at age 70 now. I don't know.
So putting the PPMS aside for just a second, because that is important. The mechanism of action of Kesimpta and Ocrevus is really very, very similar. They're both anti-CD20 monoclonal antibodies. They both hit a sort of population of B cells. If a person is doing great with what they're on, I'm usually not that excited about switching them to something else. But when we say someone's doing great, it's how do they feel? Are they having side effects? But with these drugs, it's also what do your labs look like? So, with these B cell therapies, we would like to see that your total lymphocyte count's normal, that your T cells are normal, but that that one population of B cells should be low, because that's how these drugs work. Antibody levels, IgG, IgM, we would like those to stay in a normal range. So it's possible that a healthcare provider could talk about moving to another drug because maybe one of those lab parameters are looking a little off, even though the person's not having infections yet. So they could be doing it preemptively to try to head off infections down the line. In all of these B cell therapies do carry some risk of infections over time. I would say our folks on Kesimpta have generally been very happy with it. Our folks on Ocrevus have been very happy with it. From a selfish standpoint as a healthcare provider, I will say that one of the things I like about Ocrevus and the drugs that we give intravenously here in our infusion center, it's a very controlled setting. I know when you got your infusion, I know when you got your labs, and if you didn't get your labs done, I know because you didn't show up for them. So there's a little bit of a control factor with the IV meds that I do like. But that said, we use a lot of both drugs. We use a lot of Kesimpta, we use a lot of Ocrevus. I have not seen huge differences in what our folks are saying in terms of how happy they are with it. I think a lot of our Ocrevus folks do like the thought that they don't have to come in twice a year and get their infusion and then they're done for 6 months.
Thank you. Somebody's asking, actually she sent an email, Kim, and she said, hello, is it possible for blood sugar fluctuations to affect MS symptoms, especially numbness and tingling in the extremities? I have A1C between 5.6, 5.9, so not enough to be considered full diabetes, but if I don't eat every few hours, I can feel my numbness get worse as I'm getting hungrier. When I check my blood sugar at those times, it's usually between 93 and 120, not extremely low or high. Would berberine be helpful to alleviate this? Do you have any other suggestions?
So when you think about those old areas of damage, those old areas of demyelination, again, they work, but they don't work as well as they used to, and they are susceptible to things that kind of knock you off your game. So if you're sleep deprived, if you're overheated, if you're sick, you have a viral infection, those old areas of demyelination may not work as well as they used to. If she had obvious blood sugar fluctuations, too high or too low, that would be a nice, easy explanation for why her symptoms are acting up. But it sounds like her blood sugars are normal. That said, I'm very humble, and when I think about the individuals with MS, people with MS have all kinds of different things that will make old symptoms act up. And for her, the food intake, even though her blood sugars are technically fine, maybe one of those things that make her symptoms act up. I think it's important for her to know that that's not a relapse. So she's not hurting anything by doing that. It's more of a quality of life issue and I think, as she kind of maybe plays with different, sort of dietary regimens, she may find ways of managing that, but I don't think it's anything dangerous. I don't know with the supplement that she mentioned that I've not personally seen that make much of a difference. Again, that's not to say she couldn't try it, but I just personally have not seen that. I'm flashing back here to that previous question on Ocrevus Kesimpta. The person said they have primary progressive MS. The reason that for that question that's important is we do need to realize that Ocrevus is the only FDA approved drug for primary progressive MS. Do I think Kesimpta could work in primary progressive MS? Certainly could. It's just not FDA approved. So in that person's situation, their insurance carrier could actually dictate what they stay on because Ocrevus is approved for primary progressive, whereas Kesimpta is not technically approved.
True. Paula said, my apologies if this has been asked before, but I'm preparing to receive an infusion after not getting one since 2020. It's like Rituxan. Considering the B cell is something that is important for fighting COVID, what is available for a patient who may contract it while B cells are almost nil?
Yeah. So, I mean, we do know from back with the Delta surge of the COVID pandemic that people on B cell therapies did have the potential to get sicker, when they were on Ocrevus, rituximab, Kesimpta, those things. Fortunately, with the newer COVID variants, that has not been as much of an issue. Blood monitoring to make sure that B cell therapy, regardless of which one it is only hitting the B cells and not T cells and not lowering antibody levels to a concerning level is one way of lowering your risk of severe upper respiratory or lower respiratory infections, whether it's COVID or other viruses. We used to have COVID monoclonal antibodies, Evusheld. We offered that to all of our patients on B cell therapies with the thought being, if you are on a B cell therapy, there's a good chance you're not going to make a lot of antibodies to vaccination. So giving you the antibodies through a drug, a monoclonal antibody like Evusheld was one way of getting around that. Unfortunately, as COVID continued to mutate and spin off more variants, the Evusheld became ineffective. And so as of January of this year, the FDA withdrew the emergency use authorization for Evusheld. Unfortunately, there's been no replacement yet. So if you were on a B cell therapy and you did get severe COVID, you can certainly use the antivirals. Things like Paxlovid are still available to you as an option.
Thanks. And this is actually an interesting also regarding fentanyl. How can we be assured, this is from Teresa, that fentanyl is not getting into our medicines through the big reputable pharmacies? It's a huge problem, and I want to know if the drug manufacturers are following strict protocols for this.
So, I mean, there is quality assurance with any FDA approved drug. So there is some sort of, batch testing for quality assurance to make sure that nothing is getting in there. Fentanyl is obviously a bad actor from a recreational drug standpoint. It's potentially lethal if you get some. And I'll take a little sidetrack here for a second. Just there may be people listening who are on prescription fentanyl. So the prescription fentanyl patches are used for severe refractory pain, and there is a legitimate use for those in pain management. If they are used appropriately, it can be a very safe, very effective drug. Unfortunately, when it's used in the recreational drug market, there's no safety controls. You don't know what dose you're getting, and it doesn't take much fentanyl in a recreational drug to kill somebody. I have not heard of any issues in the FDA approved prescription drug market of fentanyl contaminants in anything. And again, there is a lot of testing before drugs FDA approved and ongoing testing just to make sure that there's quality control over time.
Angelique would like to know, how can she break up scar tissue at injection sites after years of DMT injections?
Yeah, it's challenging with all of our, sub-Q medications and even, the IM avenex that people do build up scar tissue. Massaging the site gently, after an injection may help some, but we do see individuals that have just chronic scars. They've used that injection site over and over. I think, one of the ways of getting around that is to think about alternative injection sites. Realize when the nurses with all of these injectable companies, when they do their training for that individual and how to do their injections, those nurses have their hands tied just a little bit. They can only train you in the injection sites that were done in the initial study. There is nothing magical about those sites. For instance, if you're doing up near your belly button, with a subcutaneous injection, the nurses on the clock cannot officially say it, but you can go 2 inches from your belly button, 2 inches from that, and move way out on your flanks and pick up new injection sites and maybe avoid those areas of scar tissue. Working with your healthcare team, with the nurses there, they can show you alternative injection sites where you can pick up non-scarred sites. I tell people that all of us are worried about gaining a little bit of weight, and the person with MS says, if you gain a couple of pounds, you're not gaining weight, you're gaining injection sites for your injectable medication. Just got to put a positive spin on it.
I like that. I'll remember that one.
Yeah.
Patty said you mentioned in a previous talk regarding sensory ataxia that building up the core will help the sensations. And she's saying how?
So improving your core strength doesn't really change the sensation. It lets you adapt to the loss of sensation. So if your balance is off, sensory ataxia, because you don't have good position sense or proprioception, if we improve your core strength, we're going to help you adapt to that loss of sensation. So hopefully I didn't give anyone the impression that we're restoring sensation. We're helping you adapt to it. If we improve your function, I don't care if we restore sensation or help you adapt to it. We just want to improve your function and decrease your fall risk.
And I'm just going to throw a little thank you in there because this person's calling from the UK. They said, thank you for doing these calls. Interesting to see how American healthcare differs from ours, but really useful to hear.
Oh, you're very welcome. Thank you for joining in.
Yeah.
We had a great experience with some of your UK, your National Health System nurses years ago. We had a group come and spend a week with us here, and then we sent our contingent there to hang out with them for a while. I did learn a lesson. You don't go out pub crawling with the UK nurses.
That's something you'll have to remember.
Yes.
Okay, so Gus is asking if there's any other species other than humans that get MS, and if so, what have we learned from them?
Yeah, great question. So we really don't know of any other animal that gets multiple sclerosis. There was a little blip of interest at a primate facility. I believe it was in Oregon a few years ago, that maybe they saw something that looked natural MS-like in these primates, but nothing ever came of it. So, and the problem with that, if we are the only animal that gets multiple sclerosis as far as we know of, it makes research a little challenging. So to this day, we are still using the mouse EAE model, experimental allergic encephalomyelitis, as the animal model for multiple sclerosis. And the problem with that is several things. That the mouse's immune system is not a human immune system. This EAE model seems to be more T cell driven, and we know MS in humans is T cell driven, B cell driven, both at the same time. It does vary across human to human, as to how your MS looks immunologically. But so the problem with that from a practical standpoint is there are things that have worked in that mouse model in terms of therapeutics that did not translate into humans. And the reverse might also be true. There could be things that might work in people, but it never gets past the mouse model. And so not that we wish MS on other species, but it would make research a lot easier if there was a natural version of MS in the animal kingdom outside of humans.
Teresa said a week ago, she was listening to another Q&A, and he was saying that Copaxone is an old DMT and recommends using something newer. Your thoughts?
So Copaxone is one of our original three, back when we had the ABC drugs. And if you took, the whole world of people with MS, you could say that, yes, in general, the newer therapies, the B cell therapies, Tysabri, S1P drugs like the Gilenias and Mazents and Zeposias are in general more effective than our old injectable therapies. That said, if someone listening is on one of the original therapies, you've been on injectable therapy, and you're doing well. So if you have no relapse, no progression of disability, no new MRI lesions, you tolerate that drug, it's not an absolute given that you have to switch. We do in general now, if we have a newly diagnosed individual, we're going to try to steer that person probably towards a more effective therapy at time zero. But for the person who's maybe been on injectable therapy and is doing well, is happy with it, that's not to say you absolutely have to switch. One of the nice things about Copaxone, or the generic forms of it, gluteramine acetate, is the safety profile. I don't know that we'll ever have a safer drug as a disease-modifying therapy than gluteramine or Copaxone. It's our only therapy that we don't have to do any lab testing with. So yeah, in general, there are certainly more effective things, but we really need to look at the individual and what their situation is.
Elizabeth said modafinil interferes with her sleep. Would a short-acting Ritalin be better for daytime fatigue and preserve sleep?
So when we think about fatigue management, if we're looking at medications, modafinil has probably been one of our more effective things. There is also R-modafinil. So R-modafinil does have a longer half-life. If she's taking modafinil and having it's bleeding over into bedtime and it's interfering with sleep, she clearly would not want to do R-modafinil. The short-acting stimulants, so Ritalin or methylphenidate, Adderall, dextroamphetamine, could play a role. They do have a little shorter half-life than modafinil does. Very different mechanism of action. So modafinil is what we call a wake promoting agent, gets your brain very focused in the here and now, whereas the stimulants are exactly that. They're stimulants. There is the potential for addiction with the stimulant drugs. And this is just my experience. In all the years I've worked with MS, I don't think I've ever seen someone truly addicted to a Ritalin or Adderall medicine. So it would certainly be worth looking at. They do have a shorter duration than compared to modafinil.
Thank you. Have you had any patients who have had any luck with the Medtronic bladder bowel interstem device?
Yeah. So the idea with the interstem device is that if I can't get the signal from brain to spinal cord to bladder to have good bladder control, I'll just sort of recreate that control with this artificial device. It looks like a pacemaker. It's surgically implanted over on the side, and then you have the sort of very fine electrodes that then tap in to the sacral nerve roots to recreate that normal bladder control. There are two competing devices. So Medtronic's interstem device was the original. There's another company called Axonics that has another device. People can go online and look up, Medtronic versus Axonics. You can talk to their urologist about the kind of the subtle differences between the two. We have a number of individuals who have these devices in place, and I would say most people have been pretty happy. There is a way to do a test of before you have the surgical implantation, so that you have a sense of whether it's going to work or not before you actually try it. Along the lines of those sort of electrical stimulators, there is another way that getting sensation to the bladder, and this is through a procedure called posterior tibial nerve or percutaneous tibial nerve stimulation. So this doesn't involve surgery. This would be something where you go into a urologist and you're going to probably do a series of about 12 treatments over a few months. These last about 30 minutes. They're going to put a very fine needle electrode down around your ankle at the posterior tibial nerve and send an electrical signal up to the bladder to try to retrain it. And there is good data out there showing that this can help with some of the bladder symptoms we see with MS.
Great answer. How do you best create neuroplasticity to improve walking? Is it just to keep walking as much as possible?
So we do know that physical activity is really important for at whatever level is appropriate for the person with MS. it's appropriate for reconditioning, for your health overall, but there is some thought that it may help with neuroplasticity. There was a study years ago that looked at people with MS after an MS relapse. And what they did in this study is both treatment groups got IV steroids. One group just got the IV steroids. One group got IV steroids and aggressive physical therapy. The group with physical therapy actually had better function when they looked at them months out. And the thought was that it might have been through neuroplasticity, that we may have helped form new pathways to sort of get around that area of damage. So physical therapy, general physical activity, we think might be ways of promoting neuroplasticity. There is a device that got FDA approval in December 2022. It's from a company called Helius, Helius, and it's called the PONS, PONS, neural stimulator. What this device looks like is it looks like a headset, but you don't wear it here. You actually just hang it around your neck. Little wire that comes off and ends in a gold-plated electrode. That electrode sits on top of the tongue. It is only used during aggressive rehabilitation. So what they showed in a study in MS is that if you took people with MS who had walking issues, both groups got aggressive rehabilitation. One group didn't wear the device, one group wore the device. That both groups got better. The group that wore the device got more improvement, and it was more sustained. So this device is FDA approved. When I say aggressive rehabilitation, it really is aggressive rehabilitation. What that program looks like is somewhere between 3 and 5 days of weekly physical therapy for 3 months. On the days that the person is not doing physical therapy, they're checking in with the therapist through tele-rehab or a phone call, making sure that they're doing a couple hours of hard exercise at home. So here at Shepherd, we actually have a program working with this. Even though it's FDA approved, we felt like they needed to gather a little more data. So our program is actually running through a research protocol. The person asked a great question. So when we think of neuroplasticity, is that only for walking? No, we think if you can form new pathways, could that help with cognition and upper extremity function? So one of the things we're doing in our study is we're collecting data on walking, but we're also looking at upper extremity function and cognition to see if those things might improve also.
Gus said, you said in a previous chat that MS patients and the rule of thirds before DMTs existed. How do you know you're in the third with more mild MS?
So, great question. So that rule of thirds that we refer to is, the days before we had any disease modifying therapies, it was felt that about a third of people with MS were going to follow a fairly mild course. A third were going to follow kind of this more moderate course. Now that we have DMTs, we know that these people hopefully will change that course by having them on a DMT. And then there was a third that had much more aggressive the MS, maybe more frequent relapses, severe relapses, less recovery from relapses, or just progression of disability that was more aggressive. The only way that we know for sure that you're in that mild third right now is by sitting with you after you've dealt with MS for a long period of time and looking back over your life. That's not the ideal way of determining whether someone's in the mild third. We would like to be able to sit with you at time 0 and say, I think you're going to be in that mild third. We have to be pretty humble about making that determination. It's easy to sit with a 70-year-old person and say, you were never on a DMT. You've been living with MS for 40 years. And yes, it was a nuisance for you, but you really don't have any significant loss of function. That person had a mild course of their MS. Sitting with the 20-year-old and saying, I feel confident enough that you're going to follow a mild course that I'm not going to offer you a DMT is something most of us would be pretty nervous about doing. There are certain clues that we can look at, so how severe your relapses are early on, how well you recover from relapses, what your MRI looks like. Maybe some of these biomarkers that we mentioned earlier might give us a clue. But I'll be honest with you, as a neurologist, I'm pretty nervous about not offering a DMT to someone who's newly diagnosed, just because I'm not that confident in my ability to say you're in that mild third at time 0.
I know you've discussed this before, but maybe perhaps there's something you can mention to Sarah. At what age is the best recommendation to discontinue DMT? I'm 58 with SPMS, diagnosed in 1998 with RRMS, avenex, then Gilenya, now OKIS.
So that is one of the hot topics in MS right now, is when can we stop a disease modifying therapy? And so there's the when question and there's the why question. The why, or how we might be able to stop, is because humans have go through a process called immune senescence. As we get older, our immune systems mellow. If you have a health condition, MS, that's driven by a relatively overactive or dysregulated immune system, if your immune system mellows or calms a little bit, that could be a good thing. So maybe you're less likely to have new lesions on MRI or relapses. So the study that came out recently, Disco MS, or discontinuation MS, tried to look at this. What they did is they looked at individuals 55 and up. The majority of people in that study were 60 and up, but there was a chunk of 55 to 60s. You had to have been stable for at least 3 years, no relapse, no new lesions on MRI. And then they randomized people to either stay on or go off treatment. At the end of those 3 years, the take-home message is that there wasn't a big difference between those two groups. Both groups did fairly well. There might have been a trend towards more MRI activity in the people who stopped treatment, but it was minor. One of the caveats of that study is that most of these people were on standard old disease modifying therapies, Copaxones, Avenexes, beta serons. It really didn't give us a lot of information about taking people off of Ocrevus, Tysabri, our more effective therapies. So I would say, it's not an exact science. Talk with your healthcare team. 58, is getting into that age range where you would start having those discussions. Before we had any data, I was usually having that discussion at 60 to 65 years of age. And to be honest, there is no right answer right now. A lot of this comes down to the individual's risk tolerance and what their desires are. When I'm having this discussion with people right now, it seems like I can put people into one of two camps. There are people who, for whatever reason, really want to get off their DMT. They're having side effects. They don't like being on medicines. There's a cost factor that they just would rather be off of it. And then there are people who don't want to rock the boat. They're perfectly fine being on their medicine. They know if they stopped it, they would probably lose sleep at night, worrying about, oh my gosh, did I do the right thing? And there's no right or wrong between those two groups. It's just your individual personality. So, our job as a healthcare team is to really look at those risks and benefits and try to help the person make an informed decision.
Thank you. Regina said that she's 7 years old and 20 years on Avenex. It has worked for her, but she just read that it can impact the liver. So she wants to know if you have any info on that.
So in all of the interferons, Avenex, beta seron, Rebif, Xtavia, have a small risk of liver function problems. Statistically, the highest risk was when she first started it. So usually if people are going to have liver function problems due to the interferon, it's usually going to rear its head early in treatment, in the first few years of being on it. If a person's been on an interferon for a long time and we see liver function problems, one of the questions we raise is it more than just the interferon? So when we think about medicines that our liver metabolizes, your liver function problems might not be due to a medication. It may be due to the medications that you're on. So, as we add more medicines and we're asking more and more of our liver to metabolize those drugs, sometimes we hit a tipping point where it's like, ooh, that was just one medication too many to ask of our liver. So her risk, assuming she's not adding a lot of new medicines at this point, the risk that the Avenex would cause liver function problems is pretty low.
Okay. Linda said that she was previously on Copaxone for 4 years and then on Rebif for 6 years, but recently had a flare, so she needs to consider new options. She's curious if any of the newer drugs help with symptoms along with holding back flares and stopping progression. She has RRMS, but struggles with terrible pain and spasms from MS hug to the point where it also affects bladder and bowel function at times, as well as swallowing depending on the day. After trying almost all treatments, I have found some relief with dry needling in order, but not much else has helped. Would just be interested if any DMTs also would help with that.
So I would think of those as two very different issues. So when we think about what we want with the DMT, think of the DMT as like your insurance policy for the future. What we hope with the DMT is, number one, you tolerate it, and then we're going to prevent relapses, prevent new lesions on MRI, and hopefully prevent progression of disability. What we don't expect the DMT to do is help with symptoms you already have. It's not that we can't help, but that's a separate treatment bucket. So think of your DMT going forward as preventing new stuff. And then we still want to focus on getting rid of and managing the symptoms you've got. It's just that you don't want to expect your DMT to do that. If you had a breakthrough relapse on an existing DMT, that is cause to have a discussion to say, okay, can I do better? Can I move to something that's more effective? And certainly we have things that might be more effective than our older injectable medicines. But then we still want to, while we're doing that, help manage your symptoms and whether it's the pain, the bowel bladder symptoms, any of those things. So two different treatment goals.
Thank you. Patty said, I think you mentioned there was an FDA approved device requiring extensive rehab, and she wants to know the name of that. And I'm going to type it into the chat so everybody can see it.
So I would Google the company first, HELIUS, Helius, and the device is called PONS. So it's a capital P, little O, capital N, S as in Sam.
Actually, I tried this. It's not letting me type it. Aaron, if you're there and available, if you could type that into everybody, because it's not allowing me to type. But if you could give that to me once again, and I'm going to make sure it goes in.
So the company name is Helius, HELIUS. And the device is the PONS, PONS.
Okay.
If you go to their website, they've got some cool videos on how we think it works and kind of goes through some of the background information. What the company would like to do is reach out to physical therapists in the community who have an interest in working with MS and get them trained in using this device. So people are listening. If they have a local physical therapist they've worked with, you can let them know, hey, if you go on this website, there's a specific link on the website for physical therapists to click on, and it will tell them how they can get the training in using the device.
Thank you. Diane wants to know, is there a drug for fatigue that you can take on and as needed, on a needed basis for MS?
Yeah, so both your modafinil or modafinil can be used on an as needed basis, and your stimulant drugs, your Ritalin, Adderall type medicines can be used on an as needed basis. Older amantadine or Symmetril, that really needs to be a maintenance medicine, so you need to take that on a daily basis. But your modafinils and stimulants can be used as needed.
Kim's asking if the PEMF and vibration mats help with peripheral neuropathy.
So these vibration plates, that if people haven't seen one, it looks like one of the old-fashioned scales that you would weigh yourself with. So there's a base and then sort of a stem that goes up and then handles that you hold on to up top. And what that base does is it vibrates or oscillates at this incredibly high frequency. There is data showing that it can actually improve balance for people that might have a sensory ataxia. These things have been used to improve bone density in people with osteopenia or osteoporosis. I've not seen them actually restore sensation or get rid of pain, but it's more for the balance issues or bone density issues. Physical therapists may use these in their facilities. Some exercise facilities actually have these available.
Paula said, is it a good idea to have the latest COVID booster before the infusion of Rehabnate or 6 months post-infusion?
So if you're on a B cell therapy, which is that, so that's one of the what you mentioned is Rehabnate. So there's Truxima, Ruxience, Rehabnate, and those are all biosimilar forms of Rituxan or rituximab. We really don't know what the ideal timing is. The politically correct answer is that we would do it like in between your infusions at the 3-month mark. I don't know that we have a lot of good data to say that that's the perfect timing. If you look at people on a B cell therapy and they're established on it, in reality, their B cells are depleted the week before their infusion, 2 weeks after their infusion, 3 months after their infusion, because that's what the therapy should do. So I don't know that the timing of the vaccination really is going to practically make that much of a difference. But again, the politically correct answer is about 3 months after the infusion.
Thank you. Do you have time for 2 more?
Sure.
Okay. So Linda's asking, where else can you inject the Avenex pen? IM is different.
Yeah, so intramuscular, you're a little bit more limited. So the traditional sites are deltoid, top of the leg, the thigh, and then your gluteal muscle. The gluteal muscle, you probably want to have a nurse kind of show you where to do with that, because in theory, if you are a very thin person and you could in theory bump into the sciatic nerve, you'd have to be really thin, and a nurse again can show you where to do an IM injection on your gluteal area. But so abdomen is not a site for intramuscular injection, so it's really going to be arm, leg, and butt.
Okay. I've been on Avenex 25 years. I'm 62. What do you think about switching to Mavenclad?
So Mavenclad's an interesting animal. If we're talking about how we get people off of therapies at some point, we're thinking about stopping your therapy. Mavenclad might be that nice transition, because you can do your 2 oral doses of Mavenclad. You do Mavenclad now, a year later you do another course, and in theory you're done for life. And so that could be a nice exit strategy for people that are looking at getting off their therapy, but maybe they're a little bit nervous about just stopping everything. So again, Mavenclad could be a nice option to do that.
Thank you. I'm going to stick in one more. So
Yeah.
Karen said, in your clinical experience, what percentage of MS patients achieve, and I don't know how to pronounce this word, but SENESCENCE?
Senescence. Yeah.
Okay. After age 65 plus.
So all humans go through this process of immune senescence. So all of us have an immune system that mellows out as we get older. The problem is we do it at different ages, and we don't have an objective way of measuring at this point. So again, this gets back to that biomarker discussion. We would love to have a biomarker that says, yes, Mrs. Jones is at the point she has achieved enough immune senescence that she no longer needs to be on a disease modifying therapy. We don't have that blood test with 100% confidence yet. So right now it is a risk benefit discussion, based upon studies like the DISCO MS trial, and that individual's risk tolerance about, are they willing to take some small chance that maybe their MS acts up if we stop their disease modifying therapy, or they would just rather not rock the boat?
Okay. Well, we do have a couple more questions, but we could keep going and going and going. So I think we can save it for the next time.
Awesome.
Yeah, because you have a night to go back to. So anyway, that brings us to the end of our conference. If you've missed any part of it, it has been recorded as usual, and it will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access those recordings, or to sign up for our newsletter, which tells you all about the upcoming events. Our next teleconference will be this coming Monday evening at 6:00 p.m. Eastern, and we're going to have Patricia Bobrick, who is a PT, and she's going to be speaking about tips and tricks to make management of your symptoms easier, and she's wonderful, so come join us. As you leave the conference today, a survey will appear on your screen. We ask you to take just a moment to give us your feedback on the program today, and also your suggestions for future topics. We can be sure to provide you with the best and most meaningful programs that way. Our sincere thanks to all of our attendees and for your participation, and not only for that, but also to Dr. Thrower, who does this every month for us, whether it's a program that he's got a topic or whether we do Q&A. We really thank you for all of your participation in helping us.
Thank you.
So, educating the community is definitely something you love to do, and we feel it. So anyway, goodbye, everyone. Have a wonderful night, and we'll see you next time.
Take
Thank
care, everybody.
Bye.